Good morning, everybody. Today we are going to present a very interesting case. He's a 67-year-old gentleman who had a coronary artery disease. He had 2 bypass surgeries, and all the 3 grafts are occluded. He presented with acute pulmonary edema, and on investigation we found that this guy had a raised troponin T. We did an angiogram and found that all the coronary artery bypass grafts were blocked. He had in previous 2 angioplasties to right coronary artery. Both the stents were patent, but the posterior descending artery had a 90% stenosis, which we stented, and the patient got relieved of his acute coronary syndrome. He continued to be having acute attacks of pulmonary edema, and because of the recurrent attacks, we thought that he could be having a renal artery stenosis. He also has a history of LV dysfunction. His ejection fraction is 35%, and on the renal Doppler and ultrasound we found that his right kidney is atrophic and is non-functioning. He is just surviving on the left kidney, and the left kidney renal artery has a very tight stenosis, almost up to 95 to 98%, and the renal artery is actually huge. It measures about 9 to 10 millimeter on a CT angio. Then the other important issue here is that this patient has a very angulated neck, although the length of the neck is okay, but he's got a very, very angulated neck, followed by a huge abdominal aortic aneurysm, and then the iliacs, both the iliacs are tortuous. The other issue here is this patient is having a little raised creatinine. So what we are going to do here is we have got both the groins exposed. I'll just discuss the CT angio again. Now here this is the CT angio, and you can see what I described. There is a very angulated infrarenal neck, although the length is adequate, which is about 28 millimeter, and then there's a huge aneurysm. We also see that internally there is a dissection in the abdominal aortic aneurysm, and probably that was the reason that for the last 2 days the patient is having severe backache. So as a result, we took the patient in an urgency, and now what we are going to do is place a device. The real challenge here is how to select the right sort of device and how to deal with the renal artery stenosis. We had 2-3 options. We actually initially thought of a fenestrated graft, but then we thought because of the angulation it may be a contraindication and it may be out of an IFU use. So then the other option was that we should stent the renal artery through the bare struts of the endurant graft. Because of the angulation in the neck, we thought the endurant would be the best device to use in this case. And what we did is we first dilated the left renal artery using the coronary system, 014 system. We dilated it with 2.5 millimeter balloon and then with a 5 millimeter balloon, and left the wire there so that in case the strut comes in front of the renal artery ostium, it may be easy for us to wire the renal artery again. We are taking a 28 millimeter into 145 centimeter device from Medtronic. This is an endurant, and I'm just going to show you how we prepare the device. We actually take out the stellate, and then there is a side port. We make it air-free by injecting saline and keep the nose cone up so that there is no air, and whatever air is there, it is pushed out. And then we wire this device, and on the wire we actually take it up to the point where we want it to, and I'm going to show you on the fluoroscope how we proceed there. What we do is there is a central marker in the figure of 9. We want to keep it anterior, and once we position it anterior so that we are sure that the contralateral gate is going to open at the place where we want to, so that it will be very easy for us then to actually negotiate that contralateral gate with the wire, and we can proceed with putting in a contralateral limb. We withdraw the sheath by anti-clockwise movement of the blue handle, and this is a very controlled sort of a withdrawal, and we can deliver all the struts one by one, and now we are delivering the ipsilateral limb. This is very good about the Medtronic, Endurant, and also the Cook's device. The movement is quite good. So now what we do is we rotate the lower wheel in a direction, clockwise direction, so that the bear springs are released, and we can actually anchor the device properly. After this, we push the whole assembly a little upwards and then do a counterclockwise rotation or movement of the lower wheel, and this would resheath the nose cone, and after that we withdraw the whole assembly slowly and slowly back from the main device and the ipsilateral limb. Now the next step is that what we are going to do is take a Reliant balloon from Medtronic. Now this is a compliant balloon, and we need to fix the neck, and we also need to fix the bear springs so that we can hold the device very well on the aorta. It provides a good fixation and a good seal, and after that we balloon on the lower part, the landing zone of the ipsilateral limb. After that we are going to take this wire out and then ask the surgeon to close the arteriotomy so the patient does not have ischemia in the limb for a longer time. Now we dilate the bear struts to fix the device. Then we come down and dilate the lower part of the ipsilateral limb. There was some stenosis at the aortic bifurcation, so we want to dilate this area well. And after that, we dilate the lower part of the ipsilateral limb and then take out the device. The next step is to go from the right femoral artery with the right coronary, Judkins right 5 French coronary catheter from Cordis. We take in a thermo wire, and this engaging this contralateral port appears to be very simple, and I'm sure we can do it. And it goes in very easily, the wire and the catheter, and then we take the catheter up, all the way up to the main body and to the bear spring and above that, and we try to rotate this catheter, and we are very sure that we have gone through the device and not behind the device. Once we are sure of this, we put in a stiff guide wire all the way up to the aortic arch and into the ascending aorta, and then take this catheter out and then put in a contralateral limb. The next step is to take the contralateral limb. Now once you've got a wire across the contralateral port, and this is the limb from the Medtronic, we are going to pass this over the guide wire. We have used a Archer wire, and we prepare it in the same way, and we go through the right femoral artery. It requires a 16 French sheath. So actually it does not require a cut down, but here we have done a cut down because the patient was anesthetized and we had a very good surgeon to help us out. We put the markers of this contralateral limb at the same level as the markers in the flow divider, and then slowly with the same movement of the blue handle, an anti-clockwise movement, slow movement, we actually release the device, the contralateral limb, all the way down. You can see these movements, and it corresponds to the withdrawal of the sheath. Now after this, we withdraw the whole assembly from the contralateral limb assembly, take it out, and by this time we have completed our procedure for abdominal aortic aneurysm. We could fix the device very well, infrarenal, just starting below the renal artery with the covered portion. We could manage the angulated neck, and we had good landing zones, and we had no endoleak in the end. The second thing, what we thought initially, that we'll probably go from the radial or the brachial and do this renal, but I think if we go from below, we passed in a catheter and we could hook the renal artery through the bear struts, and we had a 0.14-inch guide wire into the left renal artery. So that gave us a good mark. And our plan now is to go through the bear struts, pass in another 0.14 guide wire, and then on this guide wire dilate it with a coronary balloon, and then pre-dilate with a 5 millimeter balloon, and then probably use a stent, maybe a Palmer stent, say 8 or 9 millimeter in diameter, and go through the struts and do the renal artery stenting. This is my approach as of now, and I think we should be successful in doing this. We are taking a 7 French RDC catheter from Cordes, and we have passed it through the right femoral artery, and we have gone through the stent graft, and through the bare struts we can successfully hook the renal artery, and after hooking we have passed in a 014 all-star wire, and on the wire we have taken a balloon, and we have dilated with a balloon, and this is a 5 millimeter balloon. After that, we have withdrawn the balloon and pushed in the guiding catheter into the renal ostium, into the proximal part of the renal artery. This allows the delivery of the stent. It makes it very simple, and once we position the stent, we can actually pull back the guiding catheter. We are going to use a 9 into 28 millimeter Genesis stent, and this stent is from Johnson & Johnson Cordes. We want to purposely use this because it gives a very good radial strength, and once it is going through the bare struts of the aortic stent graft, I want that it should hang into the aorta, and it gives an extra fixation or anchoring to the stent graft which we have put in the aorta, especially in an angulated neck. So now we have done the renal artery stent, and this is a DSA picture. You can see we have adequately dilated the stent, we have put it into the renal artery, we have achieved the right size of the stent, we have anchored the aortic stent graft very well, and I am very happy with the result because this is the sole surviving kidney for this patient, and I am sure this is going to give a very good result to this patient. He would be relieved of his pulmonary edema, he will probably improve his renal functions, and he is also treated for his abdominal aortic aneurysm, which was having an impending rupture and a sort of within the aneurysm he had a small dissection flap and an ulcer. So this is the final result. You can see we have got the completion angiogram. We've got a very good sealing and of the proximal aorta. There is no endoleak. The neck is fixed very well. The landing zones are fixed very well. There is no endoleak there. The stent, the renal stent is fitting in at the right position where we want it to be, and we can see the pre and post picture on this side. You can see how nicely we have done this, and I'm sure the patient is going to be benefited by this. So now we have finished the case. The challenge here was, one, that this patient had a severe coronary artery disease, was too high risk for abdominal aortic surgery and a renal artery surgery, bypass. The patient had a successful angioplasty of the coronary arteries, and the patient had a successful angioplasty of the renal arteries. The challenge was that he had a very angulated neck with the renal artery stenosis in a sole surviving kidney. And I'm happy the procedure went on very well. It's been very wonderful to be presenting this case to you. This is my team, Dr. Chopra, Dr. Sachin, and my senior technician, Mr. Shyam. And I hope in future we would be meeting you soon. Thank you very much. Bye-bye.